Hello, I'm Julianne Good, and this is Psych One-on-One. We are here to make psychology understandable with tips for you and your family and friends to make your life easier. Tonight, my special guest is Dr. Jennifer Defeo. Welcome, Dr. Jennifer.
Thank you.
How are you?
Good. How are you?
Wonderful. Thank you.
Excellent.
So tonight, our subject is going to be on health psychology. And what exactly is health psychology?
So health psychology is the study and focus on individuals who have health issues. Mm-hmm. So things like, what do you do when you first get diagnosed with breast cancer or a chronic illness? And so what we do is we work alongside of medical professionals and sort of help individuals transition psychologically through some of these harder issues that they're faced with. So, yeah.
And many more people, it seems, are coming down with more illnesses that are going to need some psychology, need some counseling work. How do you come into play during a situation like that?
Okay. So oftentimes if I get a referral or say from a medical physician, which is rare, because one of the issues that we have in the field is that individuals be diagnosed with breast cancer or whatever cancer, whatever it may be, and they're often from a medical model like, okay, this is what you need to do to get better, but they don't say, here, go to a psychologist, go to a therapist and talk about some of the issues that's going on. So for example, chronic pain patients who come in, I will look at what is specific to the chronic pain. So for example, fibromyalgia is a big one now. Mm-hmm. And so my first goal is to find out what medications they're taking, what doctors are they seeing, what kind of medical health link are they working with? Are they working with a physical therapist? What kind of treatment is going on? And then the goal is for me to connect with these individuals so that I can advocate for the patient, not only in the perspective of let's make sure that everything is solid with you, that you're getting all the help that you need, but then I can get feedback from those individuals on what is the progression, what is the severity, and compare it to the individual's actual functioning.
And fibromyalgia is a really tricky medical diagnosis to be working with. When I was in the medical field, I was working with fibromyalgia patients also as being a licensed massage therapist, and it was almost like the body was holding on to a lot of tension and pain, and it felt a lot like armoring. Now,
yes.
Do you work with that armoring mechanism when you're doing psychology with these patients?
Yes, I actually have a client that I work with who has that, who is sort of guarded, who will be stuck in bed for 7 days, not eating, not doing anything, which borders, can they care for themselves, right? So they go into the depression. And so part of that is lifting that armor because they're so afraid of, if I do one little thing that will trigger the fibromyalgia, then I'm going to be bedridden. And they will essentially, some people have frozen shoulder. I'm sure you've seen that, yes. Where they're literally stuck. And so part of my thing is to, one, not only work with what's in the moment, but work on what can you do, what kind of coping skills can you do so that if you do have an issue, you can bounce back quickly because you cannot cure fibromyalgia. Right. You cannot cure many of these issues, but psychologically, they're going to become more depressed or more anxious. And so knowing that that's never going to be something that's cured. And so from that standpoint, I work with them on not only do you have to deal with the guarded, the armor, but also letting go, relaxing, and looking at those key features of the depression, anxiety, or whatever else may come because of it.
Yeah, and the depression and anxiety and any chronic illness is going to make it worse.
Yes.
It's going to compound almost feeling like maybe a victim.
Yes.
So do you have to work also with that sort of mindset, is that, I have this chronic illness and now I don't know what to do with it.
Yes.
And therefore I am at this illness's mercy.
Yes. And there's two things I want to comment about that, which is a really good point that you bring up. The first is, the biggest key that I work on is, let's externalize whatever it is. Say, for example, fibromyalgia. Let's externalize that from you. You are this person. You are this individual. Mm-hmm. Let's take fibromyalgia or cancer or whatever it is away and look at your identity. Because what happens is individuals now go from, I am a mother, I am a father, I am whatever I am, to I am fibromyalgia, I am cancer, I am whatever the disease may be. Mm-hmm. On the second issue with that, as far as pulling apart and sort of separating the illness from them, is how do you want to approach that? Now, talk to it. Tell it what you want to say to it, because many people are disabled. They have kids that they can't go and play with, little ones, and the kids are going, I want to play with you, I want to play with you, I want you to be active, and they can't do it. And the reason being is because they're held back a bunch. So they essentially, what I work on is I use a lot of the grief and loss model to say, all right now you're grieving the loss of what your identity was prior to being diagnosed. And what's that like for you? And when they can process it and understand that, then they're able to sort of recognize that they've been grieving. And what can we do now so that you can get yourself back to where, maybe not where they fully were, but where they can be.
Exactly. That's a great way to be processing out some very deep emotions. And they almost have to look at it from, who am I now? Who am I with this chronic illness?
Yes.
And I think you brought up a very good point, Dr. Defeo, in that a lot of patients, once they get into the medical model and medical system on a chronic basis, the clinicians also may be saying, this diabetic woman or this, cancer-ridden man or whatever, and then start identifying them by their diagnoses,
yes.
which also compounds into, them taking on that labeling
yes.
of being that diagnosis.
Yes, exactly. It's interesting because when I have individuals who have some sort of medical illness and they come in, usually the first session they leave lifted. And what I mean by lifted is they feel hope, because all they want is for somebody to get them, to say, I understand what you're going through. I understand what this must be like for you. And in the medical field, it's like, here you go. This is what you need to do. And you're not going to be able to do everything you used to be able to do. You need to learn to just get over that. Give them a bunch of pain pills and send them on their way. Whereas when they come in, I say, there is hope. You can still go out there, maybe not depending on if they were extreme sports person or whatnot, but there are ways that you could still find quality of life. You just we need to sit down and figure out how that will work.
It'll be modified.
Yes. And they leave feeling this sense of relief and a sense of hope, because oftentimes they say, nobody has ever gotten me. Nobody has ever understood me.
Do you think, from a psychological standpoint, that could have contributed to the process of establishing that disease in that person?
Definitely. I think especially for research shows that for individuals who have chronic illness, oftentimes the depression is what makes them, because they get depressed, maybe because of grief and loss, maybe because they can't do things they used to be able to do, but that the pain itself increases based on the depression. So if you lift the depression, they don't experience pain as severe. Not saying it's not there, but they're more focused on that pain, so it becomes more severe to them. So if we can sort of essentially lift the depression or lift whatever's underneath them, whether it's hope, whatever, they tend to be able to see things in a different light, and the pain actually lifts.
That's phenomenal.
Yes.
Do you deal also with elements of hypochondriosis?
Yes. And I'm glad that you bring that up, because I have had patients where they've come in with chronic illness, and it's legitimate, and then all of a sudden another illness is coming up, or another issues coming up, and I'm going, is this somatic? Is this hypochondriasis? Is this, what else is the body manifesting due to the fact that they have this one thing and now they're very sensitive? Because research again shows, and I've seen it, depression, anxiety, anybody with a chronic mental illness or physical illness are the ones that are most tuned into their body. So constantly they are becoming aware, or they're aware of, all right, today am I happy? Today am I sad? Today am I in pain? Today am I not in pain? So they're so super aware of their body that any little thing pops up and it's like, what could this be? Is this a brain tumor? No joke. Is this a brain tumor because I have some sort of tingling in my hand? Is this, whatever it may be? And so they're super hypersensitive about their body and the awareness.
So they're almost analyzing themselves then and getting over concerned. So there you have another element to deal with, is the chronic worrying.
Yes.
Is this going to get worse? Is this going to trigger off another illness?
Yes.
And what about when you add in the like taking pain pills, taking antidepressants? I mean, that can almost either help or mask the symptomatology.
Yes.
So how do you work when that is also a component of having to deal with the therapy work?
Looking at, I'm a big proponent of medications as far as if they're needed for antidepressants and the anti-anxiety meds or whatnot. Okay. One of the issues though is I will have somebody come in and they'll just list tons of different pain pills, and I'm saying, this is part of why you can't get out of bed. This is part of why you're having such a difficult time doing the things that you may have done in the past, because these medications are making you extremely tired. And many individuals that I will actually work with or treat will say they've gone to rehab because they got addicted to the pain pills, because not only did it help them with the pain, but it helped them become emotionally numb.
Right.
And so there's that addictive factor. So this is the big question in our field. Are pain meds overprescribed? Are they underprescribed? What do we consider too much or too little? And it's a case-by-case basis.
It is.
It really is.
Yeah. And you can never know unless you're, again, working with the doctor, and then hopefully you have a good rapport with their main physician, and then you can talk about, are these medications helping? Are they contributing to some anxiety, some more elements to the psychological picture than need be, because it's very complicated situations for a lot of the patients.
Yes.
So where would you go with a patient that has multiple symptoms, multiple medications, and maybe even multiple doctors? Where do you even begin to approach that patient for starting the healing process psychologically?
That's really good. One of the first situations to see who is the primary care physician. Once you know who the primary care physician is, then the primary is supposed to be in charge of everything. So if it's a neurological issue, they should have a neurologist. If it's whatever it may be, who these oncologists for cancer, whatever it may be. And so they should all be sending records to the PCP, primary care physician. So the PCP is the first person that we want to start with and say, hey, so my client has told me that you are the primary care physician. I also know that they're seeing this neurologist. I also know that these are the prescriptions prescribed by this person, by this person. Are you aware of that? And sometimes you will see where the PCP does not know. And that could be an issue with, well, the neurologist will give the pain medicine, but the PCP knows more information about that client shouldn't be taking this anymore because of addictive factors. So sometimes they may, clients could, in fact, if they believe that the medications are what's making them better, go to other doctors and seek it from other people and not tell the PCP. So the first spot to start is with the primary care physician, contact the neurologist, and find out what are the treatment plans. Send me your treatment plan. Tell me what X, Y, and Z, what is your goal for the client? What have you referred to? What haven't you referred to? Are there any other sorts of outlets depending on the issue? Chronic pain clinic. What have you done? What has worked? What hasn't worked? And that's the biggest piece. It's a lot of essentially case management as well.
And then you need to rely on the patient being completely honest with you, and sometimes that may not happen.
Yes.
So when you're working with clients and you're feeling a resistance of them telling you exactly what kind of medications they're taking and how many different doctors they're seeing, how would you approach that with a client?
One of the things that I do is I tell them about, in order for this to work, you have to be honest with me. You're coming to me because you want help. I'm here to help, but the only way I can help is if you're honest with me. I mean, that's as far as I can go. The other piece is having them list everything out and putting the pieces together. And that is important for medical patients, any medical patient, to do a comprehensive assessment so that I could put the pieces together like a puzzle. And if something's missing, talking to the patient, saying, you know what, you told me you were taking this. However, I'm not seeing that this has been prescribed. I've talked to this doctor. I've talked to that doctor. So tell me a little bit about where you're getting this from. Because sometimes, like, for example, fibrofog. I don't know if you've heard of fibrofog.
No, could you explain that, please?
Yeah. What that is for individuals with fibromyalgia. It's called fibrofog, and they get very disoriented, confused. It's almost like they're in a fog. Okay? And so what happens is they have decreased attention span, decreased ability to remember things. And so what happens is sometimes they'll have medications and they'll forget what they're supposed to stop taking and what they're supposed to start taking.
That could be dangerous.
Yes. And so that's part of the illness, which is fibrofog, one of them. Many, depending on some of the other illnesses, there may be a lapse in memory and judgment. And so their day-to-day, they forget, did I take this medication? Did I take this medication? Was I supposed to take this? And they'll just pop it. And so sometimes it's not them being, I don't want to say malicious about it or not wanting to tell me the truth. It's just that they are confused.
And don't have a good tracking system to be able to tell, oh, I've already taken this, I don't need to double dose on this or whatever. And that, again, that could be really dangerous.
Yes.
So is that part of your case management also, is keeping track of where, the times of the medications, the administration, maybe having a good support system in place that they can also track that?
Yes. Definitely, especially when it comes to dementia patients, Parkinson's patients, AIDS dementia patients, to where the family system needs to be involved to help them recall or place everything in order, because they will forget. It's called prospective memory, which means their memory of understanding what they have planned for the day decreases significantly in dementia patients and also in patients who are older. We consider elderly above the age of 65. So that starts to diminish on a normal process. Not only that, but significantly for dementia patients. And so they will forget to take their pills. They will forget these things. And so they need either a nurse or somebody there who's going to say, okay, here's your reminder. Here's what you need to take. This is your doctor's appointment for the day. So many times they look non-compliant, but it's just that the memory's not intact.
And so, again, the tracking system would be a really good thing to do.
Yes.
And also taking into consideration that some of these medications may also play into their memory.
Yes.
It may diminish it.
Yes. Or impair it, especially pain medication. Significantly, it impairs judgment, it impairs memory, and it impairs a lot of things. So it's very important that they understand the side effects as well.
Yeah, and that is important to talk to them about that several times, about what some of the side effects that may occur, so that when it happens, they understand. They can call you up, they can call their doctors up and say, hey, this is what's going on here, and I think I need some help with this.
Yes.
So, just keeping everybody aligned in the team for the benefit of the patient.
Yes.
What is one of the hardest patient populations that you've had to work with medically so far?
I would say probably fibromyalgia. And the reason why I picked that one is because this fibromyalgia used to be a myth. So many individuals, many medical practitioners, a lot of people are now understanding it and saying, yes, it exists, but you can't really tell from imaging or different things like that, like x-rays, any type of imaging. And so these individuals used to be told it's in your head. So when I get long-term chronic fibromyalgia patients who come to me and say, you believe me. You believe that I have this pain and their symptomology is there. Yes, this is real. And so that's been a difficult sort of approach. That was a big focus of mine in my program. I have my PhD in clinical psychology with a health track. So we focused on a lot and that was a big focus of our program, for the reason being that it was developing back then. It was something that many people said it's in your head. So they thought they had psychological issues, and then that would take them down as well. So I think that probably is one of the largest. I think the second largest is male breast cancer. And working in clinics before, I've never had a patient in my private practice, but working in clinics where this existed, for a man to have a female sort of problem or issue, so to speak, they were very reluctant to treatment. It was very embarrassing and things like that. So I would say that would be the second largest or hardest population.
So it seems like the health issues that are highly misunderstood,
yes,
are the most difficult to treat.
Yes, because people are going, tell me what is wrong with me. Tell me what's wrong with me so I can fix it. And when there's no diagnostic tests that can help these individuals figure out what's wrong, here is where the anxiety and everything, am I crazy? Am I this? Is it just in my head? And these poor people aren't being effectively treated because they don't know what the issue is. It's called idiosyncratic. So idiosyncratic is when, say, for example, somebody says they have stomach pains and they go to the hospital and they say, we can't find anything, but we're going to say that you have some stomach inflammation or something around the stomach, and it consistently happens and they can't figure out what it is, but it's very real to the client. And then eventually they figure out a diagnosis down 8-10 months down the road. That person's like, I've been suffering because nobody could figure it out for me. And so my job as a psychologist is to work with the coping skills to deal with the pain and also help them to make necessary connections of individuals that can help them further.
And be accepting and non-judgmental of where they're at.
Yes. And say, this is real. This is very real to you. And so let's talk about that. Let's talk about how it's impacted your life and what's it like to be in the unknown. Because that's anybody in the population. If they're in the unknown, they're scared.
Yes.
And their mind is going to go wherever it may be, from stomach pain to cancer, because they're going, what's wrong with me? What if it is cancer? And they're thinking the worst. So my job is to sit down with them and go, let's take it step by step. Let's not go all the way to the dark place yet. Let's talk about where you're at and how we can link you.
Yes, one step at a time.
Yes.
So, Dr. Defeo, what could you recommend to our viewers if they're going through chronic pain problems and want to get help from a psychological standpoint?
I would say, one, see if any psychologists are connected or therapists are connected to the hospital where they may be, or doctor where they're being treated. I would say, look, you can go to psychologytoday.com and search for individuals who focus on specifically chronic health issues or chronic pain issues, because it's a different forte, right? We're trained in a different way than a regular clinical psychologist. So there's a different aspect. So you want to find somebody who maybe focus or has experience working with that specific population. They can also contact me, and I can, no matter where you are, you can contact me and I can try to find somebody in your area that I may know of. So that's where I would start.
Okay, and your contact information, Dr. Defeo?
Yes, so my contact information, they can go to my website. It's www.jenniferdefeophd.com, and all of my contact information is on that website.
Thank you, Dr. Defeo. That was some very helpful information, and I hope that was helpful for you viewers. If you are experiencing any chronic pain problems or health issues, please consider getting psychological help along with your medical help and use it as a team approach. And get some help. It's very important to your healing process. I am Julianne Good. This has been Psych 101. Thank you so much for watching. Take care of yourself. Take care of each other. Bye now.